Today, actually, we are very happy that in this afternoon program, we start with two really decent programs. Márton Péter Kulyassa and Csenge Erzsébet Szigetvári will try to defend, we will see at the end, their PhDs. And we have a really, really brilliant committee here. First of all, it's a great pleasure and privilege for me to welcome Rainer Schulz here. Thank you for coming over. He is a brilliant physiologist working in cardiac field. He is really internationally recognized about his research in preconditioning, reperfusion, ischemic cardiac part. He has a long connection with Semmelweis University, especially with Peter Ferdinandi, who is working in this field. So he will lead both committees. And we also have here other international people today. We have Marcel Tantau from Cluj, from Romania. And we have here Octavia and Andronik from Bucharest. Thank you for coming. And of course, we have here two highly recognized and distinguished professors from different universities. I am very happy to welcome András Lox from Semmelweis University, who is an intensive care specialist, and Péter Kanizsai from the University of Pécs, actually, and he is leading the emergency unit at there. So I think the committee set up with really distinguished people. And of course, the committee is also extended to other members. We have here Bence Szabó, who is a senior biostatistician at Center for Translational Medicine. And we have here Darius Valentin Sando, who is taking a secretary position and the methodology expert position in the committee. And I think now we will have afternoon programs, what I will introduce later on. I would like to thank for the whole committee, for everybody come here, enjoy the next two defense, and enjoy the today afternoon.
So again, ladies and gentlemen, dear distinguished guests, dear Professor Schulz, thank you everyone for coming. Thank you for the opportunity. And I'd like to introduce my PhD student. Márton Péter Kulyassa, MD, was born on the 21st of December in 1992 in Miskolc, Hungary. He completed his secondary education at the Gyulafényi Jesuit High School in Miskolc, dating 2003 until 2011. In 2011, he was admitted to the Faculty of Medicine at Semmelweis University, Budapest, where he obtained his medical degree in 2017. During his university studies, he was a member of the Frigyes Korányi College of Advanced Studies from 2011 until 2013, and spent a year at the Friedrich-Alexander-Universität Medizinische Fakultät Erlangen-Nürnberg in Germany from 2015 until 2016. He started his TDK research in 2014 under myself in the Heart and Vascular Center of the Semmelweis University. Following his graduation, he commenced cardiology training at the Heart and Vascular Center of the Semmelweis University, working as a cardiology fellow between 2017 and 2024. From 2019, he started studying interventional cardiology at the invasive cardiology department of the same center and joined the interventional cardiology scientific working group. In 2024, he was appointed as a cardiologist and in parallel as an assistant lecturer at the Heart and Vascular Center of the Semmelweis University. Alongside his clinical activities, he has pursued scientific and academic training as well. Since 2020, he has enrolled into the PhD student at the doctoral school on the Theoretical and Translational Medicine's Semmelweis University program, and from 2021 with the Translational Medicine Center. In 2022, he won the yearly Best Original Article Prize of the Hungarian Society of Cardiology, and in the same year was Student of the Month in the Translational Medicine Center. Between 2023 and 2024, he expanded his academic training by participating in the Clinical Science Scholar Program of Harvard Medical School, USA, held in cooperation with the Semmelweis University. In 2025, he spent a one-year practice in the Universität zu Freiburg Herzzentrum Bad Krozingen as a guest doctor in advanced percutaneous coronary procedures. His main research interests lie in the field of interventional cardiology with a focus on intravascular imaging, restenosis, vascular access, and translational approaches to optimize patient outcomes. He's fluent in English and German at the C1 level, regularly delivering presentations and participating in teaching activities in both languages. He has an impact factor of 18, citation index of 28, and a Hirsch index of 3. Thank you very much.
Thank you for the introduction. Dear panel members, dear colleagues, dear audience, I'd like to present to you my PhD research about optimizing outcomes of percutaneous coronary procedures. I'm a cardiologist in the Heart and Vascular Center of Semmelweis University. My supervisor is István Ferencédes and my SMS was Mariang. I had 3 specific projects, of which are 2 randomized controlled trials and 1 meta-analysis, and I will start with the first one. This is the optimal treatment for coronary drug-eluting stent in-stent restenosis, or OPEN-ISR, a prospective randomized multicenter clinical trial. The name itself is quite ambitious but definite, as in-stent restenosis occurs in approximately 10% of PCI, or percutaneous coronary intervention cases, and treatment mainly contains a drug-coated balloon, DCB treatment, or drug-eluting stent implantation, or DES. This DCB is advantageous in many respects. However, DES-ISR, drug-eluting stent in-stent restenosis, a second layer of DES is moderately more favorable. So in this case, DCB is advantageous because you don't have to implant a second layer of metal. However, it didn't prove to be better in clinical trials and meta-analyses. And there is a new player in the game, the sirolimus-coated balloons, or SCBs, which needs further evidence to support its non-inferiority compared to paclitaxel devices, PCBs, or DES in DES-ISR. So we designed a trial with patients in the setting that no high bleeding risk, structural damage, edge dissection, severe calcification is present. The diameter is equal or bigger than 2.5 millimeters, and full balloon expansion can be attained by the predilation. Our aim was to reduce the necessity of recurrent revascularization following DES-ISR treatment. We designed a 2 high-volume university center randomized controlled trial. Our hypotheses were that DCB therapy is non-inferior to a new layer of DES in DES-ISR cases when both therapies are appropriate. Also, that SCB is non-inferior to the more established strategies, and quantitative flow ratio, QFR, relates to more clinically important outcomes. So we had a population of chronic coronary syndrome or acute coronary syndrome patients when DES-ISR was confirmed, and successful lesion preparation was attained with NC or scoring balloons. We performed randomization in 1:1:1 fashion to the PCB, SCB, or the everolimus-eluting stent ES arms. If the procedure was successful, we performed follow-up angiography at 6 months, and OCT, or optical coherence tomography imaging, was performed based on operator decision. We assessed outcomes our primary outcome was late lumen loss. There was acute gain as secondary outcome, net gain, device-oriented composite endpoint, or DOCE, delta QFR, which is the change of the QFR, and we assessed the data of 108 patients by 3 assessors. So the baseline and procedural characteristics were similar. Most of the stents who developed ISR were 3rd generation. Most of the lesions were focal, and scoring balloon was used approximately half of the cases. And also the follow-up times were similar, and there was no statistical difference in this. The primary outcome was late lumen loss. This is the change of minimal lumen diameter from the index procedure to the follow-up with quantitative coronary angiography assessed. And we performed a man-Whitney test with Hodge-Lehmann confidence interval calculation, and we had, based on the available data, 0.25 millimeter absolute difference as the non-inferiority margin between the 2 arms. And for the primary outcome, we examined a combined DCB arm, so the combined PCB plus SCB, versus the ES arm. And we attained an upper confidence interval of 0.1, which didn't cross the non-inferiority margin, therefore we concluded it to be non-inferior. I also show the distribution of the late lumen loss of DCB and the ES arms, and it can be seen that the DCB was higher, it peaked in the smaller late lumen loss measures. The acute gain and net gain, which were secondary outcomes, which I present. In acute gain, we performed Kruskal-Wallis tests, which showed a significant difference between the three arms. Therefore, we performed Dunn's post hoc test, where we found that the ES had a larger acute gain compared to the both of the DCB, so the PCB and SCB arms. This is in line with the current available literature. Net gain, which is a better measure to compare the two different modalities, the drug-coated balloons and the drug-eluting stents, showed no difference with Kruskal-Wallis test. Logistic regression model of device-oriented composite endpoint showed only late lumen loss associated with this harder endpoint, and no other significant associations were observed, and the device-oriented composite endpoint were mostly because of the target lesion revascularization component, lower values of target vessel myocardial infarction, and sparse deaths were observed in the clinical trial during this 6 months observation. And also, we can conclude that both DCBs displayed a favorable tendency. We also performed the linear regression modeling of late lumen loss and delta QFR, which showed a significant association between these two values. This is an important new information that hasn't been investigated in detail yet. And OCT was utilized only in 24% of patients, therefore statistical analysis was not feasible in this regard. So to conclude this trial, DCB is non-inferior to a new layer of deaths in DES-ISR treatment at a limited sample size and follow-up time, and where SCB and PCB performed comparably well. Late loss as a surrogate outcome is associated with device-oriented composite endpoint and delta QFR, but also, as the guidelines state, intravascular imaging should be systematically used in DES-ISR treatment to better personalize every treatment decision during the way. And also, clinical roles of DCB and DES have already diverged over time since we designed this trial, and there is no class effect of DCBs, therefore it is important to see with critical results and to implement them properly. My second project is a meta-analysis in the same subject, which has the name drug-coated balloon therapy is more effective in treating late drug-eluting stent in-stent restenosis than the early occurring one. Its background is that early DES-ISR, which develops in the first 12 months after the index PCI procedure implanting DES, is mainly due to mechanical factors and neoantimal hyperplasia, where late DES-ISR mainly develops after, which develops after 12 months, is often driven by neoatherosclerosis. DCB therapy avoids extra layer of stents and reduces thrombosis risks, but its efficacy may differ between early versus late DES-ISR. If stent age could predict outcomes, it could serve as a surrogate marker helping to tailor therapy, especially in the cases where no intravascular imaging is available for the decision. And in this regard, no prior meta-analysis comparing DCB outcomes in early versus late DES-ISR was performed. So our aim was to optimizing DES-ISR treatment to minimize repeat revascularization. We set the clinical question, does the clinical presentation of timing of DES-ISR affect the outcomes of DCB treatment? And we hypothesized that DCB is more effective in early DES-ISR than in late. So we had post-PCI patients receiving DCB treatment for DES-ISR. We had the exposure arm where early DES-ISR with the comparator late DES-ISR, and the outcomes, the primary major adverse cardiac event outcomes containing target lesion vascularization, cardiac death, and myocardial infarction. We also investigated these separately and also target lesion thrombosis and target vessel revascularization. We performed a systematic search in 5 databases. We found initially 832 records. At the end, there were 4 trials eligible for inclusion to the meta-analysis. And we had enough data for 2 outcomes, which were the major adverse cardiac events outcome, where we performed random effects model analysis, and we found 1.68 odds ratio for the late DES-ISR compared to the early one. That means that the early DES-ISR patients had the earlier DES-ISR patients has 68% higher risk odds to have major adverse cardiac events outcome. Also, we performed random effects model for the target lesion revascularization outcome, where we had 1.69 higher odds for the early DES-ISR group. That means that 69% higher odds had the early DES-ISR group to develop target lesion revascularization during the observation time, that was 12 months. So to conclude, the age of the implanted stent could be an important prognostic factor in the case of DES-ISR, but intravascular imaging is a preferable method for guiding therapy. Also, our modest sample size and event size may limit generalizability. There was also present in the studies heterogeneity, and also retrospective design of studies could limit the interpretation of our results. And also the lack of pathomechanisms data may warrant confounding in this regard. Also to conclude that further data on DES-ISR clinical presentation time and concomitant intravascular imaging in randomized setting is required. So my first project was the radial artery puncture hemostasis evaluation, or RAPHE. This is also a prospective randomized multicenter clinical trial. Transradial access, as known, is the gold standard for percutaneous coronary procedures, and patent hemostasis with mechanical compression is demanding. Patent hemostasis is a method where you apply non-occlusive compression on the radial artery that limits the long-term complications and as radial artery occlusion, which still occurs in 1 to 33% of the cases. Also, hematomas are in 5 to 7% of the cases of radial artery puncture. And bioactive agents combined with a self-adherent RAPHE may provide simplified hemostasis and lower complication burden. These devices are the ketosane device, which is a ketosane sponge with polysaccharide binds to negatively charged blood cells, creating a rapid mechanical seal. And another one is the potassium ferrate that releases ferric ions, activating platelets and desiccates blood and lowering pH and forming a stable seal. These were firstly used in the battlefield, and they entered medicine in the last decade. And our aim was to minimize the incidence of complications following radial artery puncture with a simplified hemostasis method. So we hypothesized that bioactive devices will be non-inferior in safety and efficacy to standard mechanical devices while reducing human resource needs, compression times, and patient discomfort. So we had designed a trial where the patient comes for TRA coronary angiography. They were screened with ultrasound, and if the radial artery diameter was bigger than 1.8 millimeters, then and the patient was eligible, we performed randomization stratified by clinical center in 1-to-1-to-1 fashion into 3 arms. There were 2 interventional arms. One was the ketosane sponge with a self-adherent elastic wrap. The other one was the potassium ferrate device, also with a self-adherent elastic wrap. And the third, the comparator, was the usually attained mechanical compression device, which was in this specific situation a pneumatic one. We performed for all 3 1-minute manual compression, And then for the 2 intervention arms, a 10 minutes occlusive compression with the self-adherent elastic wrap, while with using plethysmography, we gradually decompressed in every 15 minutes the pneumatic compression device to attain patent hemostasis. After 110 minutes of non-occlusive compression, rewrapping occurred, and then we removed the devices, and we performed peri-procedural control for these patients. After this, we discharged them from the hospital, and they came back after 60 days for follow-up ultrasound again. And then we assessed together with the peri-procedural and the 60 days controls results with outcomes, which were a device-oriented composite endpoint containing radial artery occlusion, radial artery damage, and hematoma, also compression times and extra device usage as secondary outcomes. The baseline and procedural characteristics were similar between the study arms as it would mirror a proper randomization. Our primary outcome was the device-oriented composite endpoint, for which we used a risk difference with Farrington-Manning test and home-bone Ferroni correction. And in this regard, the devices were assessed to a 10% non-inferiority margin based on the available evidence. And they were non-inferior every arm in the pairwise comparisons as shown in the figure. We also assessed hierarchical logistic regression model of device-oriented composite endpoint, including the interaction between randomization and participating center, and there was no difference between the hospitals and also between the arms, which are shown in the confidence intervals crossing 1. And there was also secondary outcomes, which were the compression times, the extension of initial compression time if it was needed. Further 10 minutes of compression was applied to the different devices. And numerically, the potassium ferrate had the lowest value, while ketosane and MCD arms had a higher value. And also, we assessed the overall compression device usage time, which were similar among the 3 arms. Also, extra device usage was assessed with the need for second study device, which was the same one as the first applied based on the randomization. And here, potassium ferrate had again the best results, while ketosane had slightly more, but these outcomes were not powered statistically. Also, we observed the same tendency with the need for bailout device, which was a chosen device by the operator, him or herself. So to conclude this, our standalone hemostasis dressing with a self-adhesive tourniquet RAPHE are safe and efficacious option, at least in high-volume centers with restricted population. So generalizability may be questionable in smaller centers where they don't perform as much as we did. And, but this method simplifies care for both patients and healthcare workers, because you don't have to attain patent hemostasis. You just have to rewrap once the bandage and then assess the results at the end, and don't need continuous observation from the nurses. Also, open label was this trial. In Nature, we couldn't get blinding for the assessments, at least for the peri-procedurals. So this may introduce performance and detection bias, while power for secondary outcomes worth more trials with longer follow-up, also because radial artery occlusion may occur after 60 days of observation. And also, what I would say as a limitation, that the primary composite outcome wasn't weighed, because every outcome component were in the same weight, and they would not translate the same clinical weight at the same time. So to summarize the 3 trials we conducted, This was an integrated evaluation of contemporary strategies optimizing percutaneous coronary procedures, the treatment of DES-ISR, and radial artery hemostasis following stress radial excess. Through the conduct of the OPEN-ISR and the meta-analysis, insights have been gained into the mechanistic underpinnings, comparative efficacy, and operational considerations of DES-ISR treatment. Also, the RAPHE demonstrated an alternative method of compression with simplified care for all patients. These are my publications, and I would like to sincerely thank my PhD advisor, Dr. István Ferenc Édes, for his help, and during these years, my colleagues, Professor Hegyi Péter, my other colleagues, and my wife, Zsófia Király, and my parents, Mária Jós and Endre Kulyassa, who are here. And I would like to thank you for your attention.
Thank you very much for this nice presentation. It's a great work. However, as an emergency physician, I have some practical questions, okay? So first of all, how would I spot those who are prone to restenosis? Are there any scores or past medical history or any other signs that would alert me if a patient comes in with a chest pain?
Yes, so first of all, the medical history should be seen if the patient had an index procedure of DES implantation, but if I understand it well, you're asking which patients have the higher risk to develop DES-ISR.
Correct.
These are diabetic patients, smokers, obesity patients, whom the prior vascularization wasn't quite successful, meaning calcified vessels were treated, and also kidney insufficiency patients who are at very high risk for developing DES-ISR. So the classical atherosclerotic risk factors play an important role, and this is actually in the long-term process, which is the neo-atherosclerosis, which is very similar to the atherosclerosis of native vessels. And the other part, the neo-intimal hyperplasia, the other form of in-stent restenosis, usually occurs if the primary procedure wasn't proper or the stent couldn't be dilated, the volar position of the struts is not good, and if there is acute recoil or underexpansion of the stent.
Thank you very much. So duration is probably associated with restenosis.
Yes.
More difficult the procedure, the higher the incidence of restenosis.
Yes, it is.
Okay.
So duration of the procedure and duration after the what time passed after the index procedure also.
Right, okay. My next question is, do you perform the Allen test?
Excuse me?
Do you perform the Allen test to make sure that there is a collateral circulation?
Yes, in the trial we performed it. In everyday patient care, we try to perform it, but I would be not honest if I said that we perform it in every case.
Same in my department, so yes. Yeah, and one last question. How can you explain the 60+ day reocclusion? Because it's a very long time after the puncture.
Yes, that's a good question. Actually, the vessel needs to heal after the puncture, and there can be, of course, other factors that could influence, like what I said, the same like at in-stent restenosis, the classic atherosclerotic factors which could play a role. If the vessel doesn't heal properly at the puncture site, there is data that after 60 days still occurs some very rare, of course that's a smaller proportion than in the first 60 days, restenosis, and also in some cases an occluded radial artery can recanalize.
Okay. Okay.
So
does trauma have anything to do with it?
During the mean
on a long term, if there's a puncture here and then bangs his hand, or gets a fractured wrist or anything?
Logically, I would say yes, but there is no data about this.
There's still something to look up.
Yes.
Thank you very much. Thank you.
Thank you.
Okay, we pass on to the opponent too. There's a question. Oh, okay.
Thank you very much. Congratulations for all the studies you've performed for the PhD thesis. We know that the mortality due to cardiac pathologies is very high, and even if we have improved a lot the management of these patients, I think that the key for the fast improvement of this management is combining clinical data with a systematic review of data from literature as you have done. My question is regarding the costs of the procedures that you have compared. Do you have a cost efficiency analysis, at least for the first and last study?
Yes, thank you very much also to you for this important question. For the last one, we performed a dedicated cost analysis that I didn't include it because of time limits. But the costs of the devices and of course the non-inferiority is judged in the radial artery patency trial based on if it is lowering costs or nursing workload, and we performed this, and slightly the potassium ferrate came out the best device. The differs in working minutes and the device costs for this dedicated device, which are different in 3 arms, is around 6,000 forints, and for the potassium ferrate is a little bit lower, so about 5,500. So in that case, yeah, if you are in a high volume center, it can mean a lot in long term. Also, with the other secondary outcomes, that you don't have to use a bailout device or a secondary device, which has also has an inherent costs. For the drug-eluting stent in-stent restenosis trial, currently there are some, so it's very heterogeneous how much, we didn't perform a dedicated cost analysis for that, but some drug-coated balloons are more expensive than currently used DES. Some are less expensive, but taken that a new layer of drug-eluting stent implanted means that the patient has to take longer dual antiplatelet therapy. That it leads, usually if you have 2 layers of DES already, it will certainly need at least coronary angiography, almost without symptoms too, because these lesions are prone to develop again recurrent restenosis. It is considered that the DCBs are, taken everything together, less expensive than the DES, than a new layer of DES. So this needs further investigation. Actually, this is complicated by the heterogeneity of effect of different drug-coated balloons, which are not observed by 3rd generation DES, which is currently implanted. So this is still a little bit early to do such an analysis. But if we will have, and next week we will have the largest trial in DCB, in the TCT, then we will know which balloon to use, and we will use, if we will use homogeneously the same balloon, then we will know that how are the costs, because now they are very different in different iterations.
Okay, further questions from the committee? Okay, I have a question to you regarding the early and late in-stent stenosis. So you mentioned that the drug-coated balloon might be better early on as compared to later. But in your OPEN-ISR trial, most of the patients had the in-stent stenosis after 5.8 years. So did you check in this patient population if there are differences later or earlier time points?
Yes, so thank you for the important question. We didn't do an analysis regarding this because it would be improper if we have used, and all the studies included in the meta-analysis would have used also intravascular imaging. Then we would know what is the factor that causes the in-stent restenosis, rather the neointimal hyperplasia or the neoatherosclerosis, which could influence the outcomes. Also, it is more complicated because actually, we would have thought that in early it would be better to use DCB not in the late, but the problem is that probably mechanical factors which were observed and not documented in the primary procedures of the included trials of the meta-analysis caused that probably earlier in-stent restenosis had worse outcomes because the stents couldn't be dilated very well because the drug-coated balloon itself doesn't give any physical pressure, it just gets there the medication on the vessel and on the inner layer. So in this regard, we thought it would not be appropriate to do such an analysis. What we should do is a new trial with intravascular imaging in every case, and then it would be properly analyzed. There is actually one observational study which saw this, and which analyzed this, and there were mixed results. Some parts of the decissor occurred early, had also atherosclerotic lesions. So it's different by every patient, like everything.
So it was a very short discussion within the committee because we were very impressed by your presentations and the discussions later on. It was a very interesting presentation, interesting data, very good discussion afterwards. So the grading was the same, 100% with a 5. Congratulations again. So
I would like to thank you to all the panel members, the supervisors, all the attendants, my family to be here, and thank you.